This woman lives with pain. Every breath, every step, every movement of every day is a grinding struggle.
You get to such a stage where you can't carry on any longer because there's nothing to show for backache, is there? It's like having children, really. When you're having the baby, it's a terrific experience and it's all over in 5 minutes. When you've got chronic pain, you keep waiting for the end. You know, it'll break, it'll stop. But it just doesn't.
Imagine pain that debilitates, pain that cannot be communicated, pain that stops you working, stops you being active, saps your energy.
That's the worst part of it. Well, apart from the pain, the boredom.
Imagine pain that isolates you, makes the world a fearful place, pain that makes you avoid any human contact, pain that dulls your mind, your very existence.
I can't stand people knocking me. I won't go in crowds. It gets that bad that I can't stand anybody around me at all. And my back goes into spasm. It shoots right up the back, right up and into the back of my head. You do get periods of depression because you do reach the stage where you think, will it ever end? Will anybody ever find anything to get it better?
Even activities you once enjoyed become trials. Yet we need pain. It's an alarm bell, a vital signal to the brain that damage is occurring to the body. But the chronic pain of these sufferers is a useless pain, providing nothing but misery. At Walton Hospital in Liverpool, they're researching all forms of pain. Dr. Chris Wells and his colleagues are pioneering innovative pain-killing techniques. They have even initiated a 4-week course to help chronic pain sufferers to learn to live with their disabilities. They work hand in glove with researchers at the Pain Relief Institute next door. It's a team effort breaking new ground. Their work into this mysterious, invisible, but very tangible phenomenon is explained by Chris Wells.
One of the difficult things about pain is that you can't measure it very accurately. No one can prove a person's got a pain or not. But interestingly, a lot of pain is influenced by and influences the sympathetic nervous system, which makes our limbs hot and cold, and our body hot and cold in general. And in fact, we can measure heat or temperature of the skin with a thermograph, which sort of produces isobars giving different temperatures of the skin, and we've got plates called thermographic plates where we can measure skin temperatures to 0.1 degrees centigrade. So we can map out areas of the body and compare sides and compare areas and see differences. And acute pain is usually hot because you get inflammation there. But interestingly, chronic pain is usually cold. And a lot of people with chronic pains have cold areas where their pain is. And that sometimes gives us a clue with treatment.
Put our elbow over there. I'll see you again later. Bye-bye.
Yes, thank you.
Thanks, Joe.
Cheerio. Anywhere now, can you tell me where I touch you exactly? Can you point?
We've learned a lot more about pain in the last few years, and a major breakthrough in our understanding of pain pathways and the management of chronic pain has been the gate control theory of pain transmission.
Right. What about now? That's right, yeah. And you tell me when you feel...
As pain nerves travel on their way to transmit pain to the brain, they pass through a sort of gate in the spinal cord. Just how much pain gets through that gate depends on the activity of other nerves that can be affected, for instance, by endorphins, the body's own natural painkillers, or external stimulation. That might be rubbing or electricity. And we all know the example of a mother who rubs a child's pain better. And as she's doing this, as she's rubbing a sore area, she is stimulating these anti-pain fibres, which tend to close the gate in the spinal cord and reduce that child's pain.
To press the button each time it's cold or warm. Just try it, just for practice, that's right. Okay.
Understanding the gate control theory has led to many new strategies in pain relief.
As soon as it gets warm, you press the button.
Also, we can look at our own pain management program, where patients to some extent learn to control their own pain by doing things that close their own personal pain gate.
Tomorrow, it's up to you what you set your goal at. You may decide to put it up to 6 or 7. But the idea...
All of these patients tended to be very unfit. They had been told not to exercise by their doctors and friends, and they had found that doing things hurt, so they stopped moving. Their ligaments had become narrowed and shortened so that when they did anything they stretched the ligaments. So we knew that they had to go on an exercise program to build up their muscles, which would support their backs, and to lengthen up the ligaments.
Okay, so we'll do this. Feet.
Secondly, they were all very tense. Muscle spasm is a consequence of chronic pain, or acute pain for that matter, but in this sort of situation of chronic pain, it's no longer any use, and so we were going to have to teach them to relax their muscles. As a secondary benefit to that, we found that when the patient gained some measure of self-control over their muscles, they often gained a measure of control over their pain, which was very pleasing for them, because whereas they'd always floated like a little bit of jetsam on the seas of pain and gone to doctors to relieve their pain, they now thought, well, there's something I can do about it.
That's better. I'll concentrate. Let it go limp.
1, 2.
We felt that the group setting was very important, that they would gain benefit from being with others with chronic pain, and this has indeed proved to be the case. And the fourth thing then was the psychology of pain, that many patients with chronic pain have significant psychological morbidity, not psychiatric morbidity. They're not nuts, they're not imagining the pain, but the pain has got them down, which is normal, because you can't have pain for 10 years and not be tense and depressed. So if we can address that problem and make that better, then the pain might become less bothersome and less intrusive.
Not a cure for you. What we're trying to do on this course is help you cope with the pain a little bit better. Okay, that's what it's about.
Mike, what about taking your collar off? Do you feel it?
The course sets out to teach people with chronic pain a way of rehabilitating themselves. And it's a 4-week course, and what it's trying to prepare them for is life after the course, when they're going to have to go out and do all these things on a permanent basis and help themselves long term. I don't think our approach to pain is any different from anywhere else, except we possibly do more different treatments. We're a bit like a supermarket where we've got all the treatments available for chronic pain.
Bit strong. Just showing off the hair strong.
Like the kiss of life after this.
Cancer pain is a bit different because instead of it being an intractable pain situation which is going to go on years, it's only going to go on for months because these patients are beyond medical help for their tumour. So we can use very aggressive treatments like nerve blocks and morphine. But the morphine in some patients gives them intolerable side effects. So they get pain relief but they're too drowsy or too constipated to enjoy their life. By injecting the morphine intrathecally near to the spinal cord, we can use a much smaller dose, and so we get the same pain relief with no side effects. And so that's why we use a drug delivery system in some patients to minimise these side effects and give them adequate pain relief for the last few months of their life.
To give yourself a pump. And it's just pop, pop. You don't need to hang on too long. All right? That's it. And that should have delivered a little drop inside just as...
Do you feel anything when inside your back? It's a small amount.
No, not for about quarter, 20 minutes.
Ah, right. And then about that time after you do it, you can notice the relief, can you?
I'll start going drowsy anyway.
Yeah.
Mm-hmm. He's paraplegic after an injury.
I run the pain clinic. John Miles is a neurosurgeon. In fact, he's the senior neurosurgeon at Walton, and he does conventional neurosurgical techniques, management of epilepsy, back problems and so on, but he has a special interest in chronic pain, which is great because we have the same ward and we share patients, refer them from one to another, depending on who's got the most appropriate treatments.
Over 2 years after the accident. So in a nutshell, having convinced ourselves that this was the case, his spine has been strengthened by operation. Now, in fact, this you should be able to see fine if you just turn around, because this is what we've done.
Now, neurosurgeons tend to be fairly specialized in their activities, and I don't think that they are the best people to be running pain clinics, but they should be easily on hand and available because, after all, they do know the nervous system, which is the whole basis of pain is the nervous system. A mixture of a bone graft and a steel insert strengthening procedure. This is the steel bar that, of course, we developed in the foundation with Dr. Durbin. I think neurosurgery is a classical example of intermittent leaps forward based on technological advance. And we have become not only dependent on technology, but on technologists. And it really is only if you have a good research unit attached to your clinical unit, it's only then that you are able to make the kind of safe use of the high technology that is available and, of course, improve it. The computerization of our stereotactic technique is a classical example of how a modern facility has been accurately applied to a specific technique. I don't know how we would have got this done if we didn't have a research unit. We're talking to you. And you've had this shake for 60 years, is that correct?
60 years it done like that.
Yeah, well, it's about time you got rid of it, isn't it, really? Stereotactic surgery evolved in the 1950s, and the evolution was in relation to the urge to be able to undertake fine and precise surgery at depth within the brain without harming the brain as a whole and parts that you don't wish to harm. This was designed for several conditions. The first of all was pain, and later Parkinson, and in fact all other kinds of abnormal movements of limbs. Now, one of the improvements undoubtedly has been the application of computerization to the complicated mathematics that is necessary to ensure that a precise target is reached deep in the brain.
Minus 11. 56.
Because we got that brain really down low this time, didn't we?
Yeah, so we should compare to that.
And minus 16, because we're left. This computer application is valuable, in my opinion, because it removes much of the threat that the surgeon can't perhaps handle at the same time as handling a patient. The basic technique involves creating a space around the patient's head of known size with clear-cut markings both inside the space, that's landmarks inside the head, and around the outside like ordnance survey numbers. And having fixed this frame to the patient's head, we then simply work from the frame. We use X-rays to overlie the frame, the markings on the frame with the internal structures of the brain, and then we read off from a map where we should be going, adjusting the line of our approach, and our approach is by using a fine electrode, adjusting that to the particular target that we are going for for that particular patient. Of course, the brain is completely insensitive to physical probing, and the patient is not aware of any sensation as the electrode is passing through the brain. But it's after that that really it becomes quite exciting, because when we put some electrical current down the electrode and stimulate that part of the brain, we often see the kind of reaction we're looking for. You then simply need to destroy a small amount of tissue in that position. And this we usually do by heat coagulation, just like boiling an egg, in other words, but in a controlled fashion, so that the size of the lesion, which is only a few millimeters across in diameter, is small, but at the same time big enough to stop the movement.
In your leg? Yeah.
Good.
Squeeze his fingers again.
Lesion made. Lesion made at 5. Good. Good. Quick reversal. The amp got away completely.
Hold it up now. Well, that's very good.
That's a cracker.
That's a cracker.
The foundation has several areas or lines of research, and of recent importance has been this neurochemical area, the explanation for why is it that a patient is in pain, and of course it must be a biochemical change. Now this is a fascinating area, and it has been particularly fascinating since it was recognized that we have the ability to make our own pain-relieving substances, the endorphins. And there are many parts in the body, not just in the nervous system, the brain, where you can make these, even in the gut. We make our own endorphins, the same sort of endorphins that we see up in the brain. And they're having some sort of effect, some kind of modifying effect on the balance of pain and no pain. Now this has seemed to us a target to aim at. What is the change in the chemistry occurring in patients if we suddenly relieve their pain? And in fact we're recovering from autopsy material parts of the nervous system and looking to see whether the neuropeptides or the endorphins are present in normal amounts in the nervous system in people who have pain compared with people who do not have pain.
We managed to make the CGRP work. You can see all the dorsal horn showing up nicely there, brown.
Oh, right. You can see the laminin. Have you got the beta endorphin working?
No.
The obvious implications of this kind of research is that it may be possible simply to supply neuropeptides that are missing, that are not present in the normal balance of things. Now, if this could be, in fact, a particular chemical that the body knows how to make itself, or even better, if it was a chemical that told the body to start producing this pain-relieving substance, that would be important to know. What one would hope would be then that the patient would be able to switch on their own pain-relieving system. It was quite clear that when we first became involved in electrical stimulation, which of course is a very old technique for treating disease and pain, I mean, it goes back even to the 1st century AD. There are records of naturally occurring electricity, you might say, in electric fish being used to suppress pain. And in the last 2 centuries, of course, all respectable general practitioners had their own little black boxes where they generated electricity by turning a handle, and patients grabbed electrodes and felt the tingling. And in sometimes, undoubtedly, this was used simply for pain relief and proved effective. Unfortunately, it was used to treat all kinds of diseases, more as magic than as, shall we say, medicine, and fell into disrepute.
Then the gate control theory of pain was propounded by Meltsack and Wall, which showed that some kind of gentle stimulation could interfere with the perception of pain.
As soon as you feel the slightest kind of tingling or buzzing under either of these pads, please tell me.
We tested a great number of these skin stimulators, because some of them were relatively ineffective, some of them were dangerous. And in fact, on the basis of the information that we got, we designed our own TNS stimulator, which is a much safer and effective form of treatment.
So that's better.
The pain at the moment is in your lower back.
When one realizes that one is dealing with very protracted conditions that have not responded to conventional treatment, then we are very prepared to try unconventional treatment as long as the risk is low.
See if any of the pain comes back.
Slightly.
Even if it's only a small proportion of patients, one particular form of treatment might be suitable and applicable. The value of having them all available becomes obvious, and you become less cynical and less insular. I think it's not so much a matter of being either a surgeon or a psychiatrist. It's in many ways more a question of how good a doctor you are, as to how prepared you are to see what forms of treatment are working and therefore utterly valid to try.
Now, when the tightness goes away, I want you to go a little further. Use less than 2 finger breaths now. Can you go any further? Does it feel all right? Oh, it feels better, doesn't it? Can you go any more? We want to keep these long muscles very, very loose, okay? Good. Now...
Well, we're one of the largest pain clinics in Europe, so we have an international reputation as being a big clinic which can show people the sort of things they want to see in the management of chronic pain. So we often get people asking to come and work here, either to do a research project or more often to deal with the chronic pain problems on a practical level so that they can go back to home to their own countries and their own clinics and do the work there. So we have at the moment an American doctor, Dr. Aguirre, who is from Tennessee, who is doing just that. He's a consultant anaesthetist with an interest in pain.
This gentleman is Mr. Roberts, and he has had facial pain for 9 to 10 years. And I want you to notice the way he talks to you.
I just have this pain, and it's eventually got me down to such an extent that I just can't bear it anymore.
Mm-hmm. And what's it like? Could you describe it?
Well, it's a kind of a pain that keeps shooting.
Trigeminal neuralgia is probably the worst pain that anyone suffers from. It's very severe. It's caused by the nerve firing off a pain message in a disorderly fashion. It comes in the face, which is very richly innervated with pain nerves, and it's unexpected, as it just comes out of the blue, then it goes away. And so most people with trigeminal neuralgia who've had any other sort of pain say that that's by far the worst pain that they've had, and we think that this is indeed the case. But fortunately, it's one of the very few pains that responds very well to a permanent nerve block. So by putting a needle into the trigeminal ganglion and frying the part of the nerve which is causing the pain, we can produce pain relief.
That's it. Great. We'll screen through that and see.
We use an X-ray machine to view the base of the skull of the patient. We get them to put their head right back at an angle and shine the X-rays through, and then we can see a little hole called the foramen ovale, through which runs the nerve that we're looking for.
And there's the foramen around there.
We can then freeze up the skin and put a needle into that hole, through that foramen, into the ganglion of the nerve itself, which is the place where all the nerve fibres are bunched up together. And when we're in the correct part of that ganglion, which we have to find out by testing, by waking the patient up and asking them where they feel sensations when we produce an electrical current in that needle, when we've got the correct position, we put them back to sleep and we actually burn that bit of the nerve, and we make a small damage to the nerve in the correct position.
You do feel something now. Stop. What did you feel and where?
What that actually does is knock those particular fibres out forever, but it seems that the brain somehow utilises other fibres to take pain messages. So over a period of time that pain might recur. It doesn't always, but it might recur, and in which case we can actually do the thing again. But to all intents and purposes, on average patients get pain relief for 5 years, at the cost of a little bit of numbness to pinprick over the face.
Pop your tongue out. Can you feel that?
Slightly.
Let's just do the other side. What about
yeah.
There's a difference. But you can feel your tongue.
Oh, yes.
That's quite useful because it'll mean that you don't bite it all the time. But I think we've got you numb enough that your neuralgia will stop completely and you'll be able to get off the Tegretol.
Be straight.
Pain is a figment of the nervous system. Many of our patients come wanting us to refute what they've been told, namely that it's all in their head. Unfortunately, it is. I mean, that's all where pain is. It's only in the head. It's only in the brain, and without the brain, they wouldn't be having their pain.
So you're right, palms out.
Nobody wants to remember pain. So when it stops, it's lovely when it stops. You don't remember pain. When it stops, it's wonderful.
You've still got the pain, but you do forget about it to a certain extent. I mean, this can never be cured, what I've got, but I hope I'll be able to manage it better. It has helped me a lot, and I feel that my back is stronger. I can reach down on the floor, which I couldn't do before.
I intend to carry on with the program as far as I can. Learn more about relaxation. And then 2 more things about the house, which I haven't bothered doing. The garden and such like. I'll end up with the best garden in the district. I hope.
There is a great deal of evidence to show that some patients with chronic pain do actually die because they despair. There's certainly a very high suicide rate in patients with chronic pain. But way beyond that is the misery and the poor quality of life that these people have for themselves and for their families who have to support them. We probably spend more than £20 billion a year on back pain in this country. So the financial costs of chronic pain are staggering, and they could be rehabilitated by things like our pain management program.
Here we go. 1, 2, and last time. Here we go. Step together, step. Step together, step. Side, cross.